Hello everyone, my name is Dr. Leandro Feo. I'm a board-certified colorectal surgeon here at Del Rey Medical Center. And March is Colorectal Cancer Awareness Month. So today we're going to talk about colorectal cancer. We're going to go through the most important aspects of it, symptoms, how it's produced, what are the risk factors, treatment, so you have a better idea. Remember, March Colorectal Cancer Awareness Month, so remember to get your colonoscopy. You can talk to your gastroenterologist, your primary care doctor, or a colorectal surgeon, and we will be happy to guide you through the process and answer any questions. So let's start it. I have no disclosures. Colorectal cancer. So colorectal cancer is the second most lethal cancer in the United States, and it's the third most common cancer. For this year, the estimated new cases are approximately 104,000 cases, and from those, close to 46,000 people, unfortunately, will die. Normally, the lifetime risk for colorectal cancer in the general population is about 4-2%, with plus minus 1% in males versus females. So at what age is most common colorectal cancer? Normally in an age between 65 to 74 years old, most of the population develop the colorectal cancer. And people between 75 and 84 die more frequently from colorectal cancer. How does colorectal cancers happen? That is the most common question that I normally get. And there is a very simple line. A polyp, which is like an outgrowth of the lining of the colon, can degenerate or can evolve to cancer. So normally said that every single cancer starts as a polyp, but not every polyp will become cancer. And that's why it's important that we get your screening colonoscopy or other alternative that we can talk about later. And you will see during this talk and conversation that I will not get tired of telling you, please, please, please get your screening colonoscopy, talk to your doctor, because it's better to take advantage of the discovering the cancer sooner or earlier rather than later, because colorectal cancer is treatable, is curable, and actually is beatable if we take it and discover on time. As you see also in this screen, there are many mutations that can happen in different genes that we have. The most important are called APC, KRAS, P53. So when there is a mutation on any of these genes, then the process of outgrowing of the tumor is unraveled, increased, and you develop the cancer. If we go more a little in details, just as for the only purpose of information, two of the mechanisms are, or is called, one of them is microsatellite instability, and the second one is called methylator phenotype. And there is a third mechanism, which is actually the most common, called chromosomal heterozygosity, just for the purpose of information, okay? Bottom line, any of these three mechanisms lead to mutation, lead to a series of complex reactions that at the end will create the tumor, and then finally you will have the symptoms. A lot of people always ask me when they have the colon cancer, oh, how long have I had this? So depending on the mechanism that you have here, the tumor can develop from 1 to 10 years, and another ones can develop much faster in a period of 1 to 3 years. So that is always, again, here we go. Get your screening colonoscopy so we got you early. So risk of colorectal cancer. As you see in this slide, 75% of the time, we call something the classical path or sporadic, okay? Meaning that it's not linked to a hereditary component, okay? And one of the mechanisms, like I said at the beginning, the chromosomal heterozygosity is associated with this classical path. 50 to 20% is associated with family history of colorectal cancer. Important, this part is normally in the first degree. okay, your mom, your dad, or brothers, which is strongly associated with the development of colorectal cancer. Here we have some of the inherited syndromes like Lynch syndrome of FAP, where it stands for familial adenomatous polyposis. These two syndromes are associated with the specific mutations in chromosomes, and it can pass to the next generation, like, for example, your children. This happening, thankfully, 3 to 8% and 1% respectively. And another group that is important is the group of IBD, which is inflammatory bowel disease, and this happened approximately in 1%. Who are the patients with IBD? Those with Crohn's disease, which is very common, as well as ulcerative colitis. So why we should screen for colorectal cancer? Very simple. Decrease mortality. We want to catch the tumor early, okay, or prevent it so you don't develop the cancer, and if we catch it early, the survival is much higher. Decrease cost. Imagine if you have to go for treatment of colorectal cancer with chemotherapy, radiation, and all this. Obviously, it's a burden, not just for you as a patient, but also for the system. So it decreases cost. The different societies, like the American Cancer Society, the U.S. Multi-Society Task Force on Colorectal Cancer, the American Society of Colorectal Surgery, the American Society of Gastroenterology support about the screening colonoscopy. That being said, and that's why we're doing also this conversation, is we need to increase the awareness. So you, as a patient, come and do your screening colonoscopy, because even though we're doing better, we're still not optimal. So we are, as I present here, is about below 70%. Probably there is some variation right now, probably a little higher in the 75%, but still we need to get higher. We want to be above 80, 90%. What are the current options for screening for colorectal cancer? Obviously, the number one, okay, is colonoscopy. Why? Because colonoscopy is a little tube with a camera on the tip that we can go through your colon and take a direct vision of the colon, see if there is any cancers, any polyps, okay? And so that is the most common, and I feel that is the best option. You can also have CT colonography. I'm going from bottom to top. That is basically like a CT scan, okay, with emphasis in the colon, so we can see in the inside. With the new software and technology, the level of discrimination, the level where we can see inside the colon has been much better. You still need a bowel prep, okay? We need to clean your bowel in order to see inside. Contrast enema, basically we just gonna put some contrast through your colon, through your bottom, and take multiple pictures of your colon and see if we see any defects in the picture, like what we call apple core lesion. So that will raise the suspicion, something might be here. It might be tumor, but it can be also a polyp. That was important. Sigmoidoscopy is kind of a short colonoscopy. You just go to the sigmoid colon, which is located on your left side, left lower quadrant, and is a part of the colon that looks like a little hammock. We will see a picture further in the presentation. And you can have fecal screening tests where you got a stool sample and we run certain markers and try to detect DNA, etc., and see if there is the presence of the tumor there. Of course, the level of sensitivity of the capacity of the test to detect the tumor, it varies, okay? There is no 100% sensitive test. That being said, is the fecal screening test or the sigmoidoscopy or contrast enema or CT colonography is positive or is suggesting that there is something there, we need to get colonoscopy, because we need to go and take biopsies and see what's going on. So at the end, all route leads to Rome. So colonoscopy is the most important. Currently, we're trying to develop, and there are studies to get the colon capsule endoscopy. Basically, you swallow a capsule, and this capsule is going to take pictures, and then you move the capsule or get out of your body with a bowel movement. We're still not there yet, and still the number one is the colonoscopy. Cologuard. Cologuard is a quite common method to the screening colonoscopy these days. Normally your primary care doctor can prescribe it for you and pretty much detect DNA in the stool from the tumor. So this was based on a large study that was published in the New England Journal of Medicine. A quick description was a study done between June of 2011 and November 2012, was throughout the United States and Canada. Almost 10,000 patients were tested. The age of these patients was between 50 and 84. Average risk, asymptomatic. The primary point of these tests was to detect colorectal cancer and the secondary detection of precancerous lesions, these famous polyps that I've been telling you from the very beginning. So where were the results? The sensitivity of the test to detect colorectal cancer was 92.3%, so it's very good test with high sensitivity versus 73%, almost 74% with a fecal immunohistochemical test, just checking out with what I said, this test on the stool. The sensitivity detecting advanced polyps or cancerous lesion is a little lower. It's about 42%, but it's still better than the stools in the test. The cost approximately, and these don't take it literally, it can go a little higher down based on insurance and current price, about $600. Obviously, if is FDA approved. So in summary, so how we can do it based on the test. So a patient with average risk, normally if you do a colonoscopy, if your colonoscopy was completely normal, clean, you did not have anything, you don't have risk factors, we can repeat it every 10 years. An alternative will be a flexible sigmoidoscopy, the short colonoscopy that I mentioned to you, combined with a rectal exam and a fecal occult blood test. We're going to check for blood in your stool that is obviously we cannot see just with a human eye. Definitely the fecal occult blood test must be done annually. At what time do we need to start doing the colonoscopy? That's a pretty good question. Why? Because traditionally we're starting to do it at the age of 50. However, in a recent studies, we have decreased or bring the age down to 45 years old. And the question is, why? Well, the answer is very simple. You have noticed that, for example, let me say it again. We have noticed that the colorectal cancer incident or cases have increased in younger population. And an unfortunate example is, is the death of the actor Chadwick Boseman, who died last year at the age of 43, is not making a mistake, from metastatic actually colorectal cancer. So we have also noticed that patients on the early 40s, late 30s are getting colorectal cancer. What are the causes? Multifactorial, and perhaps we may need another session of talking like this to explain this in details. So by the way, if you want to talk more about this, you can leave your comments or message on this talk and we'll be happy to discuss further. So that is why we bring the age now to 45. If you have family history of colorectal cancer, remember in first degree, your mom, dad, perhaps brother or sister, you need to do the colonoscopy 10 years earlier at the age where your family member was diagnosed. For example, if your family member, God forbid, was diagnosed at the age of 45, you need to start at 35. Now, if it's a little later, 55, you wouldn't start at the age of 45, you start at the age of 40. So again, I'm gonna say it again, if you have family history of colorectal cancer with a first degree relative, mom, dad, brother, or sister, you start 10 years earlier at the age where that family member was diagnosed, or start at the age of 40. Lynch syndrome is a genetic colorectal cancer disease, you normally start at the age of 21, and you do it every 2 years till you hit the 40s, and then yearly after 40. Okay? And finally, FAP, you can do it every 1 to 2 years. You start a much younger age. And that is a little more complicated, intricate guidelines, so I would recommend that to discuss further with your gastroenterologist, colorectal surgeon. We will have to have genetic testing, so it's a little more complicated, and you can always contact us, call me if you need me, and we will guide you through the process. IBD, inflammatory bowel disease, Crohn's or ulcerative colitis. Again, you will need it every 1 to 2 years. Crohn's disease and ulcerative colitis has been linked to development of colorectal cancer, especially after you have been with more than 10 years of suffering the disease. So what are protective factors for colorectal cancer? Evidently, physical activity, be active, be out there, try to lose weight, high fiber diet, very common in Western diets, a lot of fried food, processed food, that's not a good habit. A lot of red meat, not a good habit. So for those people who like to barbecue everything and eating, a good New Year's strip every day, no. You can do it here and there, but it's not a good habit to have. Intake of calcium has been linked with certain degree of protection, vitamin D, aspirin, definitely. Also Celebrex, a medication out there. This has been linked to decrease the rate of polyps, and decreasing the rate of polyps automatically decrease the rate of colorectal cancer. Fish consumption with omega-3 not only protect you, your heart, also have some protective component for colorectal cancer. Risk factors that do not alter the screening colonoscopy. Even if you have this is not a contraindication. Actually, we need to control this: obesity, diabetes mellitus with insulin resistant, tobacco, alcohol. Obviously, these only are linked to colorectal cancer, but also in the overall health associated with renal disease, cardiac disease, obviously lung disease, among the most important. All right, let's now go straight to business. What are the most common symptoms of colorectal cancer? Well, as I mentioned before, the presence of blood in your stool, changing bowel habits. Now you are a little more constipated, and then you have like pencil-like stools. You may have vague abdominal pain, or you can simply have no symptoms. And I want to emphasize this. You can have no symptoms. You can be feeling normal, no issues, no problem. And then here I go again with my line. That is why it's important you get your screening colonoscopy. And I'm going to share with you a quick story. I had a patient who just came in to check a little abscess around her belly button. She was, I believe, 55 years old. And I routinely asked, have you had a colonoscopy? No, Dr. Feo, I never had a colonoscopy. I'm afraid of that. I'm a super active woman. I'm very healthy. And I went through my checklist. Do you have family history of colorectal cancer? Have you noticed change in your bowel habits, etc.? Where we just discussed, and she said, no, I'm perfect, no problem. I said, well, I will strongly suggest to you that we do a colonoscopy. You sure, Dr. Feo? Well, it's better to detect anything right now, but perhaps you probably will be no issues, but it's better to avoid any surprise. And unfortunately, we detect rectal cancer, and thankfully the patient went to treatment. We got it early enough, and she's doing great. And she was 55. I have a patient of 50, super fit on the gym, everything, same issue. But the good news that we catch it early. They went through the surgery they needed, the treatment that they needed, and here they are enjoying life. So here is why it's important to do your screening colonoscopy, or the alternative method is that what you choose. So what do we do once we encounter a polyp or a mass? Number one, the rule of thumb is we name it. We need to put a name. So that's why we get biopsies for that tissue so we can say, oh, it's a polyp, or it's colon cancer, or rectal cancer. Okay, then we have to do a staging. We need to know if that cancer has spread, has gone somewhere else, there is any lymph nodes around. And you say, what, lymph node? What are lymph nodes? Well, lymph nodes are perhaps when you have had sore throat or earache, you feel a little like nodule or a little mass here in your neck that you can feel in both sides. Well, those are lymph nodes. And we have lymph node from head to toe. Obviously, the belly is not the difference. So colorectal cancer have the particularity that they like to go first to the lymph nodes, and then they can spread somewhere else. So when we do this staging, we check in imaging studies if there is any suspicious lymph node. We check the other organs, and that's the best way to do it. So how we do that? We use some blood work, and we use CT scans. Okay, we take detailed picture of your chest, your abdomen, and your pelvis, where the rectum part is, and the colon or large bowel lies in your belly. Finally, when we know that, then we can treat it and give you the best treatment that is tailored to you and your specific features, condition, including your age, including your performance level, including your medical problems, etc. Here we have some examples. So you can see in these pictures, we have in your left upper side of your screen, you have a CT scan. That little, this organ here that you see here, this is the liver. This is your right side of the abdomen, and you see all these shadows here. All that is metastasis. Unfortunately, this patient have advanced stage. Down here, this is your chest, and these are your lungs. You see this distinctive mass here? Right, that is metastatic disease to your lungs. On your right side of your screen, you have examples of MRIs, and you see the arrow. Those are masses that are growing there that are rectal cancer. Other option is an ultrasound, where you can see also a defect in the wall. So this is one of the, these are the modalities that we use to stage and know if the tumor has spread somewhere else, in order to later on help you out and decide what's the best option in terms of treatment for you. What are prognostic factors? Age. Well, we talked that most commonly the population that is more affected is in the elderly, 65 to 80s. But as you know, as I also mentioned, now colorectal cancer is happening in younger patients. So age is not right now just exclusive of, or the colorectal cancer is not exclusive of in the elderly. This can happen also to a young population. That's why it's important we pay attention to any symptoms. You might think here, blood transfusion. Yeah. So sometimes patients can present with anemia, which is a very common way to present to the doctor, feeling very tired, very fatigued. Then we run some lab work, and we see your hemoglobin is super low. Especially if you are in the elderly side, we will immediately search for colorectal cancer. And if you has been requiring multiple blood transfusion, that is unfortunately a risk factor for recurrence that we have noticed in multiple studies, because it's associated with immunosuppression, bringing your defense down. So you might think, oh, so if I'm bleeding, I'm not going to get transfused. No, you will get transfused, because the priority is to reestablish your health. But at the same time, we wouldn't like to transfuse you frequently because of the arguments I just explained to you, and that's why we would like to treat you sooner rather than later. Perforation or obstruction. Perforation means that, as the word is like, the tumor went through the different layers of the colonic wall and just pop, basically. And you present as an emergency, pretty much, most of the time, and you may need emergent operation as well as obstruction. There is no more flow through the colon going through your rear end, and you have a bowel movements. Simple, like a pipe system at home. Something is obstructed, everything above that obstruction is starting to accumulate. So you might present now is with feeling bloated and throwing up, and then we get the different studies. We see that you may have the tumor and you need an emergency surgery. When the tumor is more advanced, it can be attaching or extending to adjacent organs. Non-common to see, for example, rectal cancer pushing into the prostate in a man, or the bladder, or the ovaries and the lady's uterus. So that's why it's important to check it out. But that also is telling us that the process is being moving forward and advanced. Histological features. Histological features mean how they look under the microscope. And there are certain features that we search, like, oh, there is present in the lymph node, if there is invasion of certain nerve, and what type of cells are involved, and all that information, it tells us this type of tumor is more aggressive, or this being linked with the chances of recurred when we have taken out, resistant to chemotherapy. So it's very important for us to put the name on the tumor and see what features under the microscope the tumor has. So in general, what is the treatment for colorectal cancer? Well, the treatment depends on the stage, okay? And the stage varies based on the tumor site and how they invade through the wall of the colon, which it will be a little complicated to explain in this setting. But stage 1 is the earliest stage, and stage 4 is when it has obviously spread through other organs, like I mentioned to you, the liver or the lungs, which are the two most common organs involved in stage 4. So normally for stage 1 and stage 2, which are relatively early stages, normally the treatment of choice is surgery, and the survival is pretty high. Stage 2, certain patients may need chemotherapy based on what I just said in my previous slide, how the tumor looks under the microscope, or if it presents with obstruction, or it presents with perforation. Probably will be a good idea to give you chemotherapy in addition. Stage 3, for sure, you need chemotherapy after the surgery. And specifically in cases of rectal cancer, and I'll explain to you in the next picture very quickly what I'm talking about when I say rectum, because I mentioned colorectal cancer, colon and rectum. They connect to each other, but we treat it similar with certain distinctions or difference in certain aspect of the treatment. And stage 4, which obviously spread to other organs, depend of how much advanced you have your disease. You may need just chemotherapy, you may need surgery, and nowadays we're starting to use immunotherapy as well, where we are targeting specific cells to help to extend your survival. Here we're gonna go, you're gonna get your first medical, class here. You didn't go to med school, here we go. This is your first class, basic anatomy. So as you see in the picture in the left side, this guy that have this large shape of letter N, I think, is the colon, this part. And it goes from right to left. This part here is your cecum, here's your appendix, which is attached to the cecum. So it's part of the large bowel and the colon. We going up, ascending colon, and then transverse colon, and goes down, descending colon. And as you remember at the beginning of the talk, I said sigmoid colon, that it was located in your left lower quadrant, in your left side down, is here. It looks like a hammock, okay? And this part here is the rectum, which lies on your pelvis. If you see in the background the bones, that is your pelvis bone, okay? They lies in the rectum, and finally here is your rear end. So how do we do surgery for cancer? And it's basically based on the blood supply, because along the blood vessel are the lymph node that I mentioned to you that we need to get out along with the tumor. So we can see it under the microscope. If you see in this picture here, it's a quick diagram of the main blood vessels that we use, that we need to resect, especially the branches that we're interested on. Okay, briefly, the superior mesenteric artery, which gives the blood supply mainly to the right side of the colon and part of the most of the transverse colon. These little branches here that I'm pointing out are the ones we take down during surgery when we have tumors over the right side. And then on the left side, we have the inferior mesenteric artery. And when we have any tumor in this location, then we take that blood vessel with the branches down. Now, these are the type of surgeries that we do, and this is what it means. When we remove the right side of the colon, it's called right hemicolectomy. If we remove the left side, in this particular left hemicolectomy, and this one, when we remove the sigmoid, is called sigmoid colectomy. When we are going down to the rectum, the terminology can get a little more complicated, so we're not going to get in details on that. But if you have any question, please feel free to contact me. So we're getting to the end of this conversation, and we can see here, because the question is said, what people listen the word cancer immediately think, am I gonna die? So that is a very important part to clarify and talk here. And I'm gonna say it again. Colorectal cancer, if we detect it earlier, that's where we do the screening for early detection, is treatable, is curable, and is beatable. Very important. So let's quick here. These numbers can vary in the literature, plus minus a little bit, but in general are those. For a tumor that is localized, stage 1, stage 2, so they have a good idea, we have 90% plus. Here is 89.8, but 90% plus of survival. And 5 years period. When we talk about cancer, we talk about survival in 5 years, 10 years, etc. If the colorectal cancer wants to come back, normally wants to do it in the first 2 years. That's when most commonly happened. For a stage regional, so for example, stage 3, the survival rate is 70% plus. And for stage 4 and more advanced, well, the numbers can be very ominous when it's an extremely advanced disease. It can be as low as 12% survival, or it can go even beyond the 40%. When we are able to give chemotherapy, you respond to this, the tumor shrink down, and we can do surgery on you. You have a pretty good chance of survive and live a long life. I have a very close friend of mine who, it was a stage 4. She had to have surgery for her liver, has had to surgery for her colon, and she's been 7 years out. So it's definitely survivable, okay? Most commonly, most of the patients will present between stage 2 and stage 3. As you can see on the left side of the screen, about 40%. But the important message here is get your screening colonoscopy, or alternative method is you don't want to do a colonoscopy. Early detection, so we can help you, we can treat you on time, and be certain that we will guide you through the process and be with you. And certainly stay calm and call a colorectal surgeon if you need help. Again, my name is Dr. Leandro Feo, board certified colorectal surgeon. And if you have any questions, you can email me. My name is leandrofeo@gmail.com. You can call my office, 561-939-0455. Thank you. Have a good day. Bye-bye.